Welcome back to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine with experts from around the country. In this episode, we're going to continue our discussion with Dr. Matt Provencher and focus on ACL tears in the military, then wrap up with the discussion on returning tactical athletes to full duty. Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allografts starts with JRF Ortho. To learn more, visit jrfortho.org.
Our conversation picks back up with an article in the February issue of OJSM from this year, titled Failure Rates After ACL Repair with Suture Tape Augmentation in an Active Duty Military Population. This Level 2 case series reported a significantly high failure rate of 26% in patients who underwent repair of proximal ACL avulsions augmented with a suture tape internal brace. The authors identified several risk factors for failure, including age younger than 17 or older than 35, elite level of competition, greater time from injury to surgery, as well as active tobacco use.
We finish up today with a discussion of ACL rehabilitation in the military population. The last article we reference is titled The Warrior Athlete Part 2, Return to Duty in the U.S. Military, Advancing ACL Rehab in the Tactical Athlete. Matt Provencher and colleagues report that ACL injuries in the warfighter population is a complex decision-making matrix that begins with proper prehab, discussion of graft choice and surgical technique, and lastly, the coordination of a well-defined and patient-specific post-op rehab plan, complete with a multifaceted return-to-duty assessment. So we're going to just shift our discussion now to ACL tears in the U.S. military, which is Catherine and I's favorite topic. And then we'll wrap up with the discussion on rehab and returning to duty. So just a little stats for our listeners. U.S. military service members have a 10-fold higher rate of ACL tears than that of the general population, likely due to physically demanding aspects of the military duties. And the treatment of ACL tears certainly has evolved over the years across all patient populations, but particularly in the military. So Matt, you've been in the military and taking care of that population for over 20 years. So what have you seen change as it pertains to timing of surgery, graft choice, surgical technique? What have you seen evolve?
Ashley, all of the above. And I think, we continue to get better, but the demands of our warrior military athletes are extreme, and it would never cease to humble me what some of these men and women would go back and do and were asked to do by, their command, by their country, and perform at a very high level. And so they tested our repairs all the time, and ACL reconstructions, not the least of which. And so we have really tried to improve outcomes by, number one, that, one of the first things we did is really help challenge the allograft situation, especially in younger folks. And so that became really a non-starter, although I think there's some, emerging evidence that we can start looking at that again, especially in certain populations. But, those that were, we didn't even look at it under 22, 25. We really upped that age to 45 or 50. I mean, you were getting your own tissue. And so that was a big part of it. We then also really started scrutinizing other ligaments, posterolateral corner, LCL, missed LCLs, huge. And we look at some of our data, some of the biggest misses, I guess, or re-injuries or other things, or maybe were implicated in a failed ACL, was missed lateral collateral ligament injury or lateral collateral ligament stretch. And without doing, and so we implemented stress radiographs, and everyone in my clinic, we had 6 sports surgeons. We all kind of, even though we were from 6 different fellowship programs in San Diego in the military, we all sort of practiced a similar brand, if you will, of sports medicine. Everyone would get a hip to ankle film first time in our clinic. What's their alignment? We started really scrutinizing the posterior tibial slope, although that's a whole nother discussion. But we really started looking at stress radiographs for the lateral caudal ligament. And that was a really important thing what we were missing back in the day. And that got a lot better and was actually implicated in a lot of our early failures. And actually, I think you mentioned it. One of the things we really tried to do and what was set up in around the country in these big medical centers were smart clinics. They're called a little different things in every service, but it was a sports medicine and rehab therapy clinic. But with those clinics, we went out to the clinics all the time and we saw the injuries earlier and earlier rather than sifting through the system and getting an ACL first time to see us at 7 months after injury. And they've already been down for 6 or 7 months. And now you have another 6 months because they get basically 2 6-month periods or maybe 3 6-month periods of limited duty to get back to their job. If they can't get their job, they basically get kicked out. So you got to get back and you got to be efficient. And so the biggest thing we did was just get back earlier. And we know that from intervening earlier, we had less secondary restraint issues, probably less lateral caudal ligament issues, less posterior horn medial meniscus secondary strained issues, less cartilage damage, and better access immediately to care. And so we work closely with our primary care sports physicians, our physical therapists, our athletic trainers, with a very big musculoskeletal group. And that's, at least I can talk about San Diego. It worked extremely well to be able to help bring those rates down, but they're still high and higher than we want in the civilian population. And that could just be maybe going back to what they do because it's, I've seen the MRIs and surgeries on NFL players and NFL combine and civilians and what we do here in Vail. It's very similar.
Yeah. And
So-
I'm curious, like the return rate, like if someone was a multi-leg and there had to be like an FCL, LCL, did they do as well?
They were a few points down on our motion scale, no question. They were a few points down on our outcome scale. Now, an anatomic early intervened ACL with LCL was almost the same as a primary ACL, almost, as long as they didn't have meniscus and cartilage. Staph meniscus, staph cartilage, as we all know, very important for ACL outcomes. So as long as their meniscus and cartilage was reasonable, the LCL, it was a couple points maybe, and I'm not even sure it was statistically significant. What was more of an issue again and again was the revision. And just like all the literature has shown, revision is not a second primary.
So you mentioned that despite all these improvements and doing the right graft choice, getting to them quickly, assessing for collateral ligament injury, the failure rate is still too high and that needs to be improved. What are your thoughts on adding an extra-articular stabilization procedure like an ALL or an LET in this population, given that they're so high risk? Are you doing that in this population? Are you seeing that being done?
So routinely, not 100%, but it's becoming, I think, more mainstream. And that's because the emerging body of data, the original data was not very compelling. And then I think the techniques got a little better. The patient selection got better just with anything. And now we're seeing, as you know, and I'm sure you've reviewed many times over, some pretty good extra-articular augmentations. Obviously, several of these you can do. And now we have to look at how to compare several, whether it's just tape type suture or it's an allograft or it's their own tissue or it's IT band or it's so now we got to deal with that conundrum of, now we got a bunch of different augments. But at the end of the day, they all seem to be helping us do better. Now, if you look at some of the biomechanic work we did here, nothing's for free. I'm not sure we're seeing it clinically, but always a concern of over constraint, rotational issues, and maybe inability to get back to that knee function that you sort of enjoy with just doing the ACL, as long as that's it. Now, because there's maybe nothing for free, but as long as it's protective enough without being overly protective, I think it's certainly something to think about.
Yeah. And then graft choice, I'm assuming a lot of it was BTB.
Super interesting. So my training bias in San Diego, because of the unique requirements of the military, was hamstring initially. So we did very interesting. And so I I learned on hamstring initially, and we did a ton of hamstring. We certainly did BTB, but a lot of prone activities of low crawls, out in the woods, diving down, jump landing. We were really concerned about anterior patellar knee pain, and hamstring's not immune from anterior patellar
No,
knee
that
pain,
makes sense.
Yeah.
but that's why we started. So, but we, I think, slowly emerged to more of a BTB, then to quad tendon, back to BTB, a little bit of hamstring, but we've really seen, we were starting to see quite a few issues with hamstring re-injury, hamstring rupture, kind of mirroring the literature. In addition, the military was interesting. We were losing the flexion torque beyond 70 degrees in knee flexion, 79 degrees, which is pretty well documented from Levy's data way back in the day, but is a little bit underappreciated in the hamstring world of having hamstring weakness. And we saw that in multiple of the military activities they would do, where you would need a high quick flexion torque to snap that heel up to your buttock or have that strength beyond 79 degrees. It's not, it doesn't come back the same after hamstring harvest.
Yeah, makes sense.
Do you feel, I'm just always curious because whenever we talk about hamstrings, I feel like where we see a lot of the negative data is in the female population. Do you think that because they did so well in the military population because you were treated mostly males in the military population, or was it pretty evenly split and still seeing good outcomes?
Yeah, so the numbers actually were probably not evenly split. That's just based on population demographics of whom we saw and what we saw. It wasn't there, and I don't think it was any exposure issue. I just think it was just sheer numbers of in the military. But saw a lot of females with ACLs. That I think is a whole nother topic in terms of hamstring and how that behaves and everything from a soft tissue standpoint. But I'm not here to poo-poo the hamstring. We did tons of them. We got away with tons, and they've done very well. I think you have to be a little careful about your selection. So people are, for me, a hamstring is non-starter in sprinter, a hurdler, where you got to snap that heel up to your buttock, long jumper, high jumper, certain military activities where you're, down low, crawling, all this type of stuff. It was just a lot of fatigue and issues in the hamstring that we saw. So, it mirrors my civilian experience as well, but it still remains very good graft. And you look at all the outcomes, even though there might be a little bit more KT 1000 side to side difference, maybe 2 millimeters, they still do pretty well.
Well, absolutely. So the evolution of ACL treatment also has included some interest in ACL repair. So one of the papers that we chose was by Craig Batoni and colleagues from OJSM, and they reported outcomes of ACL repair. They used a swivel lock and they repaired a proximal avulsion using basically an internal brace. And they found a pretty high failure rate of about 26%, and they recommended against repair in this cohort. So what are your thoughts on ACL repair of proximal avulsions in the military cohort?
Yeah, first of all, I want to give a shout out to Craig Batoni, great friend of mine. If you look in the AOSSM and the AGSM world, he probably has more primary paper awards than anyone out there. He's done a great job and has some really good level 1. Here's another good level 2 study of randomized trials to help us understand and has helped us impact practice from shoulder instability to ACL to multiple ligaments to cartilage and meniscus and others. So Craig in Hawaii has done a great job. He's got a really nice setup there to be able to do research to capture it. But this one was interesting. And the problem was when they failed pretty early. I mean, it was like less than 160 days or something. It was early. So there were some things on the multivariate analysis, age less than 17, age over 35, elite operational patients, smokers. Okay, well, another smoker situation we have to deal with. But they certainly got some back, and maybe, selection and patient selection and repair, there were some that did quite well. And so maybe this helps tighten up our selection criteria. If you do believe in repair, I do very few in my practice, just, number one, the way I did part of demographics of the practice, but also just some of my biases. But we're seeing some interesting outcomes. And when you go back to, but I have one of my great mentors, and I wish was still with us to this day, is John Fagan. And if you look at his original Star article in Core, it's a great article, and it came out with a very high failure rate of ACL repair, because he thought at West Point with curl that he could put these together and repair them. And he reported on his dismal results. And it was called the Star Protocol Star Trial. And this was way back in Core a long time ago. And it's interesting how it gets reinvented. I think there will be some indications that will stick for this, however, and we'll find good repair methods, better biology, better fixation, etc.
Well, we're going to move on to one of my favorite topics, which is rehab of the ACL, but particularly in this population. So, arguably just as important as the surgery itself, or at least that's what I say when I'm consenting people, because I believe that's when they're going to remember things, that surgery is just half. And, rehab is really just equally as important. So you published an article, so it was 2019, and it was advancing ACL rehab in the tactical athlete. So you mentioned there's been significant advances in rehab technology. You do comment on AlterG treadmills in the military population and how this can be used. Can you share a little insight to, how these treadmills are used, or any other tech that you're excited about?
Yeah, Catherine, this is great, and near and dear to your heart, I know as well, is using our resources and using the musculoskeletal community around us to help people get back efficiently, safely, and with less chance of re-injury. And so we were trying to bring in the most applicable items and trinkets, if you will, that would help some of these folks and keep them mentally engaged. And part of it's staring down 7, 8, 9 months of ACL rehab. It's brutal. I mean, in the mental, so we would, the mental side of it was really important. And so we really worked closely with our mental health professionals, our sports psychologists, our others. And so that was a huge aspect of it to keep our patients in the game. But what we did find was something like AlterG, and starting progressively on a focused, progressive weight bearing jogging program. Not everyone in the civilian world likes to run, but unfortunately in the military, everyone basically has to run. So it was something we knew we had to get better at. And so AlterGs were really ubiquitous at any of the reasonable therapy spots, which were many around the military and the world. So we had these treadmills, and then we also did some very basic instrumentation with IMUs and inertial measurement units. We started comparing folks how they were doing, not just on your single leg hop test for return to duty, but actually using some more scripted data and return to play testing that we probably started 15 or 20 years ago, with even a basic computerized assessment of side-to-side quad, hamstring differences, velocity differences, Cybex type of isokinetic testing that was really, we felt was important, but we also use that as part of the rehab. So you can do isokinetics, we have the data, and okay, do another 20 more of these. Blood flow restriction. Johnny Owens, San Antonio, my good friend, has done an incredible job with this and helped pioneer a lot of the science among many others. After learning a lot from our Japanese colleagues in terms of BFR and how we employ that successfully and safely. And so we're starting that very early. We found that to be very helpful. And Johnny Owens' data on that has helped us quite a bit. And the problem is, it gets back to what I talked about. A lot of times, these warrior athletes in the military, you only have so much time. And you're like, you're already 3-4 months into this. You've got another 9 months maybe to get better. And in the Navy, it was basically 2 6-month limited duty boards. If you weren't better in 6 months, occasionally, if you were being treated in San Diego or San Antonio or Bethesda or, big facility, you could maybe get one other because you were brought to, the big ship to get treated, and maybe you get another 6 months. So we were always under the gun to get these folks back. And if they couldn't perform, it was a huge problem. And the command would just be like, I'd rather, have another body here and take you off my roster so that I can get this job done and get our military job done. And so we were always under the gun to try to get these folks back safely and efficiently. And so that's why we were trying to employ these things right away, get it back. and some didn't work. Some I think we might have gone a little too fast on. And, we see that even in the NFL where they have access to all this. And guess what? It's still about 7 to 9 months. And that unfortunately is probably too long in the military, but we're getting better.
It is helpful to have them take that long in the NFL because we can point that out to our patients and say, see, look, they're not going back in until 9 months and they have the best rehab in the world. So you're not going back before 9 months. So it gives us some backup.
Gronk's my favorite story, 9+ months. That's Gronk.
That's rough. So you talked a little bit about return to play testing, but in your paper, you talked about that there's this gap that exists between return to play assessment of known movement quality risk factors and the use of these inertial movement or inertial measurement units or IMUs may be able to bridge that gap. Can you tell us a little bit more about these IMUs? This is the first time I had heard about this. Are you currently using this technology or do you see it being used in the future?
We use it. Yeah, it's great. And I back in the day, I didn't know about it, but it became one of our data inputs at Navy Special Warfare as part of one of our movement patterns and looking at joint movements. And so it's basically an accelerometer in a small little postage stamp type of package. It's got gyros, it's got magnets in it, and it's got 3 axes to really look at how the joint is interacting with the rest of the body. And you can use subtraction to do it from femur to tibia. You can do ankle to foot. You can do core to femur, etc. And so it really has taken down the need actually to use these 24 camera motion, very expensive sensor systems, put all these tapes on. Now, believe me, those are still outstanding. The fidelity of those is super high. And what we've really tried to do, and we have a study ongoing called Empower, but it's maximizing the warfighter rehabilitation because we do a lot of testing in a great physical therapy clinic, but it's carpeted. Guess where these folks are going back to? Not carpet. So it's jumping over rocks, it's scaling walls, it's doing all these other things. So we're using IMUs compared to our standard, even in therapy clinics, they're doing a good job with computerized isokinetic testing, other testing, and comparing that in a more real world application. So these units really make it easy to compare side to side and get really good data to see what the differences are side to side. That's really what we're looking at. Everyone's a little bit different. We do have enough data. You'll be able to create a data lake and have that and find out where your norms are and where a 23-year-old female versus a 43-year-old female should be, or a 62-year-old male skier should be after their ACL, or the 73-year-old one I did the other day. But skis and the knee is perfect. There's no cartilage, no meniscus issues, but they couldn't ski. And so it's interesting now to create this data lake and have some normatives and see where your true return to play based on your military activity. And so the DoD is really into all of this type of stuff, real world application.
Yeah, because I think everything we're doing in clinic, it's more like we're looking at movement quality and, doing the best we can, but it's not really ever going to be a real world application. And then we're also very rarely getting a true accountance of fatigue. So it's what happens when they're 45 minutes in? Do they have these mechanics? No, they don't, I think we all do the best we can, but this is something that's really exciting, moving in the right direction.
Yeah, Catherine, you don't actually, you've lived this world a long time, and there's limitations, but we also, it's the gold standard, and we've used it as a very nice way to return, get the athlete's mind behind it, which I think is probably even some of this still underestimated and underappreciated. And now, but using that and comparing that to other technologies and other ways to measure things. And I mean, let's face it, you can take your phone and track someone on the phone and get some basic movement patterns now. I mean, that's where this is all going, but the data is going to be key.
Hey there, fellow surgeons. It's Dr. Ashley Bassett
and Dr. Catherine Logan. We're thrilled to share what we think is the next frontier in orthopedics with you.
Absolutely. In our sports medicine practice, we're always looking for innovative ways to enhance our patients' recovery journey.
That's right. And that's why we're excited to talk about accelerated recovery, or XR for short. It's a perioperative recovery supplement that's been a game changer for us.
XR is surgeon formulated with clinically researched ingredients at optimal effective doses. It's designed to support wound healing, prevent muscle loss, and speed up return to functional recovery.
Totally, Ashley. And that's where XR comes in. At my clinic, we've implemented the XR nutritional optimization recommendations as part of our standard of care for patients, and the results have been really exciting.
Absolutely. I recognize that our patients' nutritional status has become an increasingly recognized risk factor for surgery. Malnourished patients face risks like delayed wound healing and infections.
Just recently, I had a high-level athlete I operated on who went through a 3-week XR recovery program. The feedback was really exciting. He had faster healing, minimal muscle loss, and overall a smoother recovery process.
And I had a similar experience. The ease of implementation and the positive impact on patient outcomes have been really motivating to continue to study.
And I tried it too. XR is a cranberry lychee drink mix. It's sugar-free and vegan, and it's safe for anyone over 12 years old.
So, fellow surgeons and healthcare providers, if you're looking to elevate your patient's recovery journey, consider XR. Let's embrace the future of targeted nutritional supplementation together.
Visit xrscience.org or xrscience.org to learn more and join us in revolutionizing perioperative care. And then the last sort of piece we want to touch on, which you kind of mentioned briefly before, is just that psychological readiness. And obviously we have like certain scores and outcomes that we can, that ACL RSI, that I think most of us sort of use. You now have sports psychologists at Vail, correct? Because that's new since I was there. So is that someone that you're sort of saying, hey, this person, there's a flag, or is that part of the routine?
I wish there was enough bandwidth for it to be 100% part of the routine, because there's no question be beneficial for, even me after my ankle injury. I know I would benefit because I was not in the right headspace for it and I was very irritated. But everyone can benefit from this. There's no question, and done the right way. And even from basic coaching, if you're completely resilient, you've got all the mental capacity and tools and your right framework to get this done, and you've got your head ready to go, then that's great. But there's still coaching and other things you can do on top of everything else. And so I liberally use this, and it's been a wonderful adjunct. We've done this for a long time, from the SEAL teams, professional sports, to the locker rooms, to everything. It's ubiquitous. And I think we need to find ways in our practice. Again, I feel we are the musculoskeletal captains. We're running the ship here. We have to bring our experts in. They want to be a part of us. I've always found that it's never a no. It's like, how do we get there? Okay, how do we get it paid for? How do we do this? How do we do? There's the details. Devil's in the details, but they all want to be a part of this. But we have to captain this as orthopedic surgeons, musculoskeletal experts, to say, here's our program for you. Here's our program for our patients, and let's optimize you.
Now, for the psychological aspect, are you screening them before, like when they come in injured, you give them an assessment? Are you screening them postoperatively or at certain intervals? Like, is there a utility to identify someone that may be susceptible for a psychological block to recovery early and getting them in early, or is it at a certain point?
Is that what you're thinking?
I'm sorry. No.
Oh, I didn't know if Ashley's bringing this up just because we just talked about Albright's study that just came out in Grit.
No, actually, but I did want to talk about that, but more just because I feel like sometimes when people come in injured, there's different attitudes towards their injury. And there are some that are like, I'm going to get better, I'm going to get out there. And then there are some that are like, just, I'm never just dismal and depressed. And I just wonder how much that can predict how they're going to do in recovery, and how much that can predict like how they're going to struggle psychologically later on in terms of return to play. So I was just wondering if screening pre, or kind of at that initial visit pre-operatively, would be beneficial.
Yeah, Ashley, you're 100% right. And you bringing this up reminds me that the Provencher psychological screening is not bad, but it's not very good. So, but I'm actually getting better and better, as we all do, as we get on in practice of, okay, you're definitely like, and believe me, I have some patients where it's like, this is non-negotiable. I am not doing your surgery because you're just not in the right space for this until and it's almost like smoking. Like, we can do the test and do this. So you stop, do the nicotine cotinine test or whatever. But yeah, I'm not doing your surgery until you get connected with a mental health professional, because this is not going to go in the right direction for you and for me and for my team. And I want this to be a great outcome. So, yes to all the above. I think we can do a better job, but it comes back to captaining this whole thing. We only have so much time in the day, so we have to find ways to do this efficiently and effectively. And, there's a ton of different aspects to this holistic approach to get someone's shoulder or knee better, or hip or whatever it is. And so that I also think is the future too, is how do we make this more efficient and bring our experts around the table?
Yeah, that's awesome. I really appreciate that. And I know we've already kept you slightly over. So
no, this is great. We keep talking all night. It's great.
My final things, I just want to acknowledge again how much I appreciate you as a mentor, and everything you've done for me as a resident and as a fellow and post. And really appreciate you sharing all your insight on a topic that, Ashley and I really care about. And also, we thank you for your service for our country, and also continuing to put out all this data. So we always close our show with something called the Fast Five. We're going to ask you 5 questions that we ask every surgeon. And then you have to pose a question to the next person, which I believe is Brett Owens. That works.
It's going to be Brett Owens. Yes.
Wonderful. Excellent.
Anything. The less it's about orthopedics, the better.
Perfect.
So Brian Lau, who was last on our show, posed the question for you. So that'll be the last question that we have for
Excellent.
you.
Good.
Not going to like it.
Uh-oh.
Yeah. Anyway, go ahead, Ashley.
So in the OR, do you use foot pedal or hand control?
Foot pedal, way more precise on off.
Oh.
I'm same. I know this answer,
Takes too long to find the button on the shaver. And then you've shaved the labrum.
Oh gosh.
I know this answer, but what shoes do you wear in the OR?
Arthroscopy boots, if not Birks, cork plastic Birks for arthroplasty, open shoulder stuff.
What is your favorite OR lounge snack?
Pistachios.
Wow.
You guys have good ones too. I miss the Nutter Butters.
Oh, those are good. Yeah.
What
I have to bring those. Those aren't part of the surgery center. Nutter Butter is. Yeah, they're still there.
What music do you play in the OR?
Ooh, so whatever the techs basically put on.
Wow.
Yeah, it's okay.
Easy going of you.
Pretty easy. It's in the zone. Yeah. One of my techs is a huge yacht rock fan, and so that's she's one of my lead techs, and so we have a lot of yacht rock, and in fact to the point where she wanted me to have for my retirement band a band she looked up called Yachty by Nature.
Oh my goodness,
it's amazing.
I mean, that's a really good band name.
It is good. It's a great name, but I didn't have it. They've got some good tunes. I mean, it's good, but
we'll have to check them out. We'll give them a shout out. Link in the bio.
So this one might be tough for you because you do so many awesome surgeries, but what's your favorite surgery?
It goes back to the military. Any shoulder instability surgery for sure.
Yeah.
Any open scope, tibia, crest, Latarjet, revision, posterior, everything. Bone graft scope, open everything.
Okay, this is your question from Dr. Brian Lau from Duke. What do you think, or Dr. Provencher, what do you think of the Patriots now?
We're rebuilding and we're getting better. It's great to be there during the years of excellence.
Yes, that's a good way to say it. And what is your question for Dr. Brett Owens?
Oh boy. Ask Dr. Owens why he thinks collegiate rowing athletes are far superior to lacrosse players.
Ooh, I'm gonna have Catherine ask that one.
Yeah.
Well, I don't know what the answer could be.
Yeah.
Well, thank you again. We'll let you sign off.
Catherine, Ashley, and again, I am so proud of both of you. You've done an incredible job. You make us all better, and congratulations on this podcast. it's great to get our information out there, and you've done a great job. So proud of you, and an honor to be here. Thank you.
Thank you. Thank you so much. Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. We love your feedback. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. Stay fit, friends.